Welcome to the Deep Dive. Today we're tackling a really significant global health issue, one that maybe doesn't always get the headline space it deserves: traumatic brain injury, or TBI.
It's definitely significant. TBI is still right up there, one of the top 3 causes of death and disability from injuries, globally speaking.
Yeah, and the scale is just immense. We're diving into a major update commission from the Lancet Neurology today.
That's right, and it lays out some pretty stark numbers. We're talking 50, maybe 60 million people suffering a TBI every single year, worldwide.
Wow, 50 to 60 million.
And the economic impact, something like $400 billion a year. It's huge.
That kind of cost, both human and economic, really demands we pay attention. So our mission really for this deep dive is to pull out the key findings from this update, looking at what's changed since their last big report in 2017.
Exactly. We want to understand, how the causes are shifting, what's new in diagnosis, and there are big changes there. And also, frankly, where the system is still failing people.
Okay. And the initial teasers in the report suggest some surprising shifts, right, in terms of who's getting injured and how we even define the severity.
Absolutely. The landscape is definitely evolving, especially around what we used to think of as mild injury. It's forcing a rethink. Okay, so let's dig in.
Let's do it, starting with that changing picture of TBI, because the causes look really different depending on where you are in the world.
They really do. If you look at low and middle income countries, LMICs, the overwhelming driver is road traffic incidents. Still, often involving, vulnerable road users, motorcyclists, pedestrians. It kind of reflects ongoing issues with urbanization, infrastructure, traffic safety.
Okay, so that's LMICs. But then you look at high-income countries, the HICs, and the story is quite different.
Completely different, almost inverse. In HICs, the #1 cause now, it's falls.
The falls, really.
Yeah. Falls account for, 52% of TBI globally? But in some European studies, it's even higher, like 56%. And this is heavily driven by demographics.
You mean older populations?
Exactly. Falls in people age 65 and up now make up 30 to 40% of all TBI hospital admissions in these countries.
That's a massive proportion.
Yeah.
And linked to things we know increase risk in older age, like frailty, maybe alcohol misuse.
Those are definitely key risk factors identified. But what's really critical and quite concerning is how this demographic shift impacts the care people receive, even in well-resourced healthcare systems.
How so? What kind of disparities are we seeing?
Well, this is one of the more sobering findings. The commission highlights that older patients, the ones injured in these sort of lower energy falls, they're about 50% less likely to get critical care or emergency interventions compared to, say, someone injured in a high-energy car crash.
50% less likely, even if the actual brain injury shown on a scan is similar.
Even if they have similar rates of CT abnormalities and similar rates of in-hospital mortality, it's quite shocking.
So it suggests a bias, doesn't it? Based on age and maybe how they got injured, like a fall isn't seen as serious as a car crash?
It seems that way. The historical focus has been on high-energy trauma. So the report makes a strong recommendation. Age alone should not be a reason to limit therapy. And we urgently need research to figure out the best treatment protocols specifically for older TBI patients.
That's crucial. Meanwhile, in LMICs, the disparity is more structural, right?
Yeah.
Just a fundamental lack of resources.
Absolutely. They bear a disproportionate burden of TBI and lack the infrastructure for good emergency care, pre-hospital care, and especially that crucial post-acute follow-up. It's a massive gap.
Okay, so unacceptable disparities, whether from bias or lack of resources. Let's shift gears to the most common type, mild TBI. You mentioned the term mild is problematic.
It's incredibly misleading, yeah. Mild TBI that's defined by a Glasgow Coma Scale score of 13 to 15, meaning the person is generally awake, responsive.
Seems okay on the surface.
Right, and it makes up over 90% of TBIs that present to hospitals. The old assumption for years was, oh, it's mild, you'll fully recover.
But that's just not what the evidence is showing anymore.
Not at all. The data is stark. Around half, 50% of adults who go to the hospital with a diagnosed mild TBI do not get back to their pre-injury health levels by 6 months post-injury.
50%. For something called mild, that really reframes the whole issue, doesn't it? It implies a chronic condition for many.
It absolutely does. It changes everything about how we should view it, manage it, and follow up.
So with 90% of cases being mild, but half of those having long-term problems, What does that do to the emergency room? How do they currently sort these patients out?
Well, that's the inefficiency problem. The main tool right now is the CT scan. But the thing is, for these mild TBI patients, 90 to 95% of the CT scans show absolutely no intracranial injury.
90 to 95% are normal scans.
Yep. So we're spending huge amounts of money, using up scanner time, and exposing millions of people to radiation, often unnecessarily.
Okay, so there's a desperate need for a better way to triage, to filter out who actually needs that scan. Which brings us to biomarkers.
Exactly. This is probably one of the biggest areas of progress: blood-based biomarkers. We're talking specifically about two proteins, GFAP, that's glial fibrillary acidic protein, and UCHL1.
And these have actual regulatory approval now.
They do, both the FDA in the US and the CE mark in Europe. They're approved as a tandem test. You measure both to help rule out the need for a CT scan in adult mild TBI patients within the first 12 hours of injury.
Rule out. So a simple blood test could potentially clear a huge number of people, avoiding the scan altogether.
That's the promise. And the data looks good. The sources suggest GFAP, even on its own, generally performs better than other biomarkers and better than the current clinical decision rules doctors use to decide who needs a scan.
So it could make triage much more efficient and safer.
Definitely safer. Avoiding unnecessary radiation, it really could become a cornerstone.
But let's circle back. A normal CT scan, even if someone gets one, doesn't necessarily mean the brain is completely undamaged, does it?
Absolutely not. And this is so important for understanding long-term outcomes. Even with a clear CT, more advanced MRI techniques, things like diffusion tensor imaging, can find subtle structural damage.
Micro damage.
Exactly. In up to 30% of mild TBI patients who had a normal CT scan. This isn't just academic. It's relevant for managing symptoms later, maybe for rehabilitation, and potentially for legal or insurance contexts, too. A clear CT doesn't equal a clean bill of health for the brain.
Okay, so diagnosis is getting much smarter, much more nuanced. But if half of people with mild TBI aren't recovering, and we know there can be hidden damage, what about care after the ER or the initial hospital stay? You mentioned gaps earlier.
This is arguably the biggest failure point in the entire care pathway: post-acute care and rehabilitation. It's consistently inadequate.
How bad is it?
Well, look at moderate to severe TBI. These are people with significant injuries. About 90% report needing rehab services 6 months later, yet only around 30% get inpatient rehab and maybe 15% get outpatient rehab.
90% needed, but only 15 to 30% get it.
That's the reality. The system essentially drops the ball once the acute phase is over for the vast majority.
And I imagine for mild TBI, given the name, it's even worse.
Far worse. They're almost completely neglected in terms of structured follow-up. Studies in Europe suggest fewer than 10% of discharged mild TBI patients get any follow-up. One big study showed only 6% leaving the ER got a follow-up hospital appointment.
6%, despite knowing half might have chronic issues.
Exactly. It's a massive disconnect between the known risk of poor outcome and the actual provision of care.
We also have to touch on TBI caused by violence. It's the third most common cause globally, you said.
Yes, and it highlights some incredibly vulnerable groups. Intimate partner violence, or IPV, is a major concern.
How does that break down?
Well, IPV-related TBI disproportionately affects women, about 75% of cases compared to 5% in men. And tragically, it's linked to nearly 3 times the mortality rate compared to TBI from other kinds of interpersonal violence.
3 times the mortality. That's devastating. And then there's the connection to incarcerated populations.
Also, incredibly stark figures there. Studies find a history of TBI in up to 64% of male inmates, and an even higher rate, up to 78% in female inmates.
78%. Yeah. That points to a huge intersection between brain injury, trauma, behavior, and the justice system.
It really does. It's not just a medical issue, it's a profound social issue, reflecting cycles of vulnerability and potentially contributing to the circumstances that lead to incarceration.
Which underscores why just looking at the biological injury isn't enough, right? The field is moving towards a broader model.
Definitely. There's a growing emphasis on what's called the biopsycho-socio-ecological model, BPSE for short.
Okay, break that down.
It basically says recovery isn't just about the brain healing physically. It's deeply intertwined with psychological factors like coping skills, pre-existing mental health, the development of new issues like PTSD.
And PTSD is common after TBI.
It is. Studies suggest around 13 to 19% of civilians develop PTSD after a TBI. And then the model also includes social factors, family support, employment, access to resources, and even ecological factors, the broader environment. It's a whole person perspective.
That makes sense. It reflects the complexity of recovery.
Yeah.
Looking ahead then, what about improving treatment itself, particularly in the critical care setting? Precision medicine is the buzzword everywhere.
It is, and it's highly relevant for TBI. For years, ICU management relied on these sort of one-size-fits-all targets, like keeping intracranial pressure, the pressure inside the skull, below 22 millimeters of mercury for everyone.
That was the standard.
That was the standard approach based on population averages, but the move now is towards individualizing those targets.
How do you do that?
Using continuous dynamic monitoring. For instance, there's something called the Pressure Reactivity Index, or PRI. It measures how well the brain's blood flow autoregulation is working. By tracking that, doctors might be able to find the optimal cerebral perfusion pressure, the pressure needed to get blood flow to the brain for that specific patient at that specific time, rather than just aiming for a generic number.
Tailoring treatment to the individual brain's needs in real time.
That's the goal. And alongside that, researchers are using advanced data analysis, like machine learning, specifically unsupervised clustering.
You do what exactly?
To sift through massive amounts of patient data scans, vital signs, lab results, and identify hidden subgroups or endotypes. Patients who might look similar on the surface but actually have distinct underlying biological processes happening.
So you could potentially match specific treatments to specific endotypes.
Precisely. Instead of trying one drug on all severe TBI patients and having it fail because it only works for a small subset, you identify that subset first. It's the path towards truly targeted therapies.
But finding those endotypes needs huge amounts of data, right? From patients all over the world. And doesn't that run into privacy issues?
It absolutely does. It's a major hurdle. You have funders like the NIH in the US pushing for open data sharing to accelerate research. But then you have strong privacy laws like GDPR in Europe that make sharing sensitive patient data across borders really difficult, almost impossible sometimes.
So it's a conflict between accelerating research and protecting privacy. How are researchers navigating that?
The most promising approach gaining traction is using federated platforms.
Federated platforms?
Yeah, the idea is the data stays put. It remains secure within its original hospital or research institution, but researchers can send their analysis tools, their algorithms to the data, run the analysis remotely, and just get the results back without the raw, sensitive data ever leaving its safe harbor.
Okay, so the analysis travels, not the data itself. That sounds like a clever way around the privacy barrier.
It seems to be the best path forward. It allows for that large-scale, multi-center analysis, which is essential for things like developing robust machine learning models while respecting privacy regulations.
All right, we've covered a huge amount of ground here. Let's try and synthesize this for the listener. What are the main takeaways from this deep dive into the latest on TBI?
Okay, 3 big things, I think. First, TBI is this massive, ongoing global health problem. But who is at risk and why is changing? In LMICs, it's still largely road traffic. But in HICs, it's increasingly about falls, especially in older adults.
And we absolutely have to address the care disparities that arise from that shift, particularly for older patients injured by falls.
Definitely. Second big takeaway. Diagnosis is undergoing a revolution, particularly for mild TBI. Blood biomarkers like GFAP are set to transform triage, making it safer and more efficient by reducing reliance on CT scans.
While remembering that even a normal CT doesn't rule out underlying brain damage detectable with more advanced imaging.
Exactly. And the third key point. We have to start treating TBI, even mild TBI, as potentially a chronic condition. The current system fails massively in providing post-acute care and rehab. We need structured, long-term follow-up that considers the whole person, the biopsychosocial factors.
Recognizing the high rates of mental health issues like PTSD is critical there, too.
Absolutely.
Okay, so let's end with the final thought. You mentioned predicting outcomes is still really difficult.
It is surprisingly difficult. Our current best prognostic models for moderate to severe TBI, things like the IMPACT or CASH models, they only explain about 35% of the variation in patient outcomes.
Only about a third. That leaves a lot of uncertainty.
A huge amount. The field is realizing that to get better at prognosis, you need to incorporate dynamic information, how biomarkers change, how physiological monitoring changes over the first few days or weeks. Early snapshots aren't enough.
Which leads to a really challenging final point for clinicians and families, doesn't it?
It really does. Think about this paradox. We know maybe 50% of people with diagnosed mild TBI won't fully recover to their baseline. But on the other end of the spectrum, data also shows that around 78% of patients who are assessed as being in a vegetative state 2 weeks after their injury do eventually regain consciousness.
Wow, 78%. That's much higher than I think most people would assume.
It is. So the provocative question is this. Given this immense uncertainty in early prognosis, both for seemingly mild cases and very severe ones, how do we, as a healthcare system, and how do families balance that uncertainty with the urgent need to provide appropriate, evidence-based, and often very resource-intensive care right now? That's the tightrope we're walking.